Welcome to this new video. We will continue the median nerve neuropathy, but now we're going to discuss the median nerve irritation or compression at the carpal tunnel area. So this is the most common, this is something to memorize, the most common mononeuropathy, meaning a neuropathy involving one nerve only. This is the most common one. And it's called carpal tunnel syndrome, where the median nerve might be irritated or compressed at the level of the carpal tunnel. So it's the most common mononeuropathy, and usually, typically, the prevalence is women. Women are more prevalent than men, and between the age of 45, 65, it's the most common age. And it's related with either traumatic or just by irritation, mechanical irritation. Could be called carpal tunnel syndrome, dynamic carpal tunnel syndrome, or compressive carpal tunnel syndrome. Usually dynamic carpal tunnel syndrome are related with at younger age, people who tend to work a lot on the computer or do a lot of pronosupination movements or a lot of repetitive movements of flex and extension, that basically stretches the nerve and irritates the nerve. And older ages, between 45, 65, can be related with just the narrowing of the space of the tunnel canal, so the carpal tunnel canal. The carpal tunnel is formed by the radius and the ulna, the distal radius and ulna, and also the flexor retinaculum, and also between two big tendons called the flexocarpi radialis and the long palmar of the hand. So the median nerve can be compressed here. It's also related with some diseases, some autoimmune diseases like rheumatoid arthritis, can cause some inflammation at the level of the wrist, diabetic neuropathy. But as I said in the beginning, the most common cause is indeed the mechanical one, unless there's a underlying disease like diabetes or rheumatoid arthritis, as an example. Just as a curiosity, we have a huge number of fibroblasts in our forearm and wrists and chins and behind our eyes. So typically diseases that cause edema and inflammation will affect tissues at the level of the forearm, leg or eyes. The typical case is a Graves' disease where the eyes protrude. But anyways, going back to the median nerve. So let's remember the anterior interosseous nerve innervates the flexor digitorio profundus and the long flexor of the thumb. So the median nerve at this level has nothing to do with those muscles. So the pronator quadratus, it's innervated by the median nerve at this level, and the median nerve at this level innervates the intrinsic muscles of the hand. So there's a nice way to memorize the muscles of the hand. Almost all the muscles of the hand innervated by the median nerve at this level, which is the mnemonic LOAF. LOAF stands for lumbrical muscles, the first and the second lumbrical muscles. The O stands for opponent of the thumb, the muscle opponent of the thumb. A stands for abductor of the thumb, and F stands for flexor of the thumb. Remember, there's two flexors. The long flexor is innervated by the anterior interosseous nerve. The short or brevis flexor is innervated by the median nerve. Just as a curiosity, the thumb, almost all muscles of the thumb are innervated by the median nerve, and some people consider the median nerve the nerve of evolution. Throughout the human life, we evolved in a way that we could manage tools and fabricate tools and manage our environment. So the muscles of the thumb are very important in terms of evolution, because thanks to the thumb we'll be able to actually manipulate the environment. And this is why the median nerve is important in that sense, because it innervates almost all muscles of the thumb except the adductor of the thumb and the extensor of the thumb. So based on what I said now, a median nerve compression at the wrist will give many times wasting, especially in chronic conditions, wasting of the intrinsic muscles of the hand. So we will see a wasting of the abductor of the thumb, of the opponent of the thumb, of the brevis flexor of the thumb. So you will see, looking at the hand of the patient, for instance, you would see, usually people, well, patients are people, but usually people without carpal tunnel syndrome will have this protrusion here, which is basically all the muscles of the thumb that I've been referring to, and we'll see this intrinsic muscles of the hand are quite strong and quite. In carpal tunnel syndrome, especially in chronic conditions, you would see a dip. You would see a depression of this area, which basically means a wasting of this muscles. And the patient will also feel less strength, especially in grip. So typically, let's say a typical patient with 65-year-old woman with a carpal tunnel syndrome with some severity will typically say, I can't even hold a glass, or she can't do this, flex the thumb, she holds the glass like this. Sometimes she says she drops things, and this is a typical carpal tunnel syndrome in its most severe condition. So a way to test the median nerve at the wrist using the neurodynamic principles, you have to tension the wrist first and then do the other parameters. We're going to do that next. Also remember, always remember, that it's possible on most nerves of the leg and arm to do a tinel signal. The tinel signal means a tapping on the nerve. So really palpate the nerve and compress the nerve. So a carpal tunnel syndrome could be positive at this tapping. Anterior interosseous nerve neuropathy could be positive at this. And this is a fundamental key, guys. Osteopaths do touch. Most doctors don't touch, so you lose a lot of information if you don't touch and palpate, and it's very important to palpate. Let's lay down on the back, please. So our neurodynamic test will start at the wrist. Now, remember, to test, we first cause tension at the area we want to test, okay? So we won't start here. We won't start at the elbow. We have to start at the wrist because we're assessing the wrist. So first position, extension of the wrist, extension of the first 3 fingers. Very important, the thumb. Look at my index, like this. And then we add the other components. So if the median nerve is basically medial and anterior, the elbow needs to be extended and supinated, and the hand needs to be extended. And then we're going to add the other components. If we do externally rotate and abduct, we're stretching the medial part of the median nerve. And then we're going to ask the patient to flex his head. So I'm going to start, not yet, thank you. I'm going to start from the beginning. Extend, supinate, extend the elbow. Look at my leg now. I'm going to take my leg, and it's going to help me on the abduction and externally rotate. When the patient starts to complain, which is basically now, I can feel the tension. I'm going to ask the patient to laterally flex the neck, the head. Don't rotate, more like, yes, perfect. And if that movement distally to the problem increases the symptoms, we have a positive neurodynamic test. So how are we going to treat these patients? Depends if it's in an acute phase or chronic phase. If it's in an acute phase, we do gliding techniques. If it's in a chronic phase, tension techniques. So the principles are always the same. Let's look at the carpal tunnel here. And the median nerve runs through here and then sends off some cutaneous branches at the first, second, and third finger. So a gliding technique, for instance, at the wrist, if the patient can tolerate that, could be like this. Extension of the wrist. Extension of the wrist. And look at his fingers now. They're flexed, they're relaxed, they have some slack there. So the gliding technique is this. You pull one end and you release the other one. So like this. And then look at my hand now. My hand is going to do all the technique. If I rotate my hand or my arm like this, I'm immediately flexing the wrist. So look at the technique now. When I put my hand in the normal position, I'm stretching the fingers, causing tension on the fingers, and the wrist comes automatically to flex position. If I dip my hand in, the wrist goes into extension and his fingers go into flexion. So if I do this, if my hand just do this movement like this, I'm doing a dynamic glide at the median nerve side, at the carpal tunnel side, okay? So like this and like this. Extend and bend, flex the wrist and stretch the fingers, okay? So it should be slower than this, should be something like this. And very soft. And again, the patient should not feel any uncomfortable symptoms. Well, symptoms are uncomfortable anyways, but he should not be feeling any symptoms because the risk of his getting worse in this case, the patient getting worse, it's immense. So you have to be careful with this. Another technique which is very valuable, and again it goes for every nerve, it's at the same time you're doing a neuromobilization or neurodynamic, we mobilize the nerve also at the same time, and especially the fascia around the nerve. Some patients in acute phase, they don't like the nerve to be directly mobilized, so we can use the fascia around, called the mesoneurial fascia, around the nerve, just to do some almost like a myofascial technique, but around the nerve. So if we imagine a nerve here, we don't go directly on the nerve, but around the nerve as we mobilize the hand. So something like this. Or we can even mobilize the carpal tunnel, let's say the flexor retinaculum, at the same time of a neurodynamic technique. For instance, I can ask the patient to extend the wrist and his fingers in a very comfortable position, and then he relaxes the hand, and he continuously doing that without causing symptoms. And at the same time, I'm opening the canal. So I'm stretching the retinaculum continue the movement, the retinaculum flexor, continue. I'm mobilizing the radius and the ulnar, continue, extend the knee, the wrist, continue, no, don't stop. And I'll just mobilize the median nerve at the same time. See, we can do a combination of techniques, neurodynamic and others. So now we're going to go to a tension technique, a tensioner technique, which is, as you know by now, causing tension on both ends, both parts of the nerve. So we're going to start at the wrist and at the fingers, tension here. We add the tension to the rest of the forearm, and this is an example of a tension technique at the level of the median nerve. So basically it's the same technique we did before in the previous video of the anterior interosseous nerve. So tension on both ends and relax. When I say relax, this is always a passive technique. I mean just relax in terms of gaining some slack of the nerve. So tension, tension. And again, this technique is for more chronic conditions, not acute conditions. And we should aim, and on every treatment, we should aim for, the goal is to gain some range of motion. Typically 5 degrees is already a big deal. So let's imagine the patient goes to the consultation, starts the treatment, and at this extension is already painful. By the time we finish one treatment, if we can gain, let's say, 5 degrees of extension of the wrist, it's already a big thing if he doesn't have any pain. And this gradually will evolve into a protocol of treatments that usually 3, 4, 5 treatments in a chronic condition is enough to treat this patient. And this concludes the techniques. Thank you.